Hello, friends. Very good afternoon to all of you. I hope you all are fit, fine, and all had attempted your yesterday subject test of the radiology and FSM. I'm not concerned about how much marks you got in your exams, but what I can say that your attendance should be 100%. I was seeing that some of you didn't attend the test, so that should not be the protocol for the future test. Make sure that you have to attempt each and every test, whatever will be or whatever is your level of preparation. Don't worry for that I'm not able to prepare this subject properly, my marks will be less, that's why I'll not be appearing. No problem, no problem. Nobody in this world is perfect in any field. Even if I say that I'm not perfect in any field, so whatever I know, that is more than enough for my activity. So don't think that until unless you are 100% sure for that particular subject only, then only you have to appear in the test. No, because in every test, if you are appearing, that it is actually a rehearsal for your final examination, when you have to face the so many stress factors, so many adverse situations, and then you have to appear in the examination, and you have to develop a habit that how to recall the past memories and what you had studied, and you have to analyze, and you have to uh, integrate the content of the different subjects, and then you have to answer. So here too we are having only the test of one subject or the two subject, but after that you will be having a mock, and here the content of all the 19 subjects will be included in the exam. Also we'll having the content of all the 19 subjects, so this will gradually build up your habit of recalling the content of the different subjects. And another very important point is that don't, as I said, that don't bother for the marks. What I mean to say, that if you are getting a very low marks, then don't upset. That cannot be the exact reflection of what marks you will be getting in your exam. Okay, or just a minute. So what I was saying, that whatever the marks you are getting, you're not supposed to bother for that. That those who are getting a low marks, don't worry, you might be the topper of the exam. Or those, if you are getting a good marks, you should be happy. But when I think, I want to say that you should not be overconfident, that thinking, okay, this my subject is 100% sure, and I'm not going to revise till the exam because my marks were very good in this exam. So you should be happy, you should be confident, but never go in overconfident. And another point is, whatever the questions we had made wrong, I always say that always do the analysis of those questions, that why you had made those questions wrong, and then only you can improve your weakness, and you will be revising those content again and again, and then you will be not repeating the mistakes, because the mistakes you should do, but the ultimate end point is that you are not going to repeat the same mistakes in your final examination. That should be the very important point. So coming back to our subject, dermatology, and yesterday we had discussed a few important topics, as we had covered the disorders of papillary squamous group, disorders of bullous diseases, then we had covered the disorders of hair. Then in the evening I had posted some questions on Telegram group, and I hope you all are a member of Telegram group. Those who had not joined, you all are requested to join the that Telegram group. And if you are not having any link, those who had not joined, please let me know, I'll send you the link. So I just want to again discuss the questions because I had seen that many of you had made the silly mistakes. So I don't want that any one of my students should make the silly mistakes for the basic questions. That should be very clear to each of you, and we are not going to lose even a single mark. So quickly we'll see that what were the telegram questions what we had yesterday. So this was the one question that all are true for the psoriasis, except we all know that in psoriasis we see the auspit sign. This is nothing when we are removing the scales, then we are seeing the pinpoint bleeding vessels. Civet bodies, yes, it is not seen in the psoriasis, it is seen in the lichen planus, so this is not a correct. Silver scales, yes, the scales are silvery. And salmon patch in the nail, yes, it is the most characteristic feature of nail psoriasis. So here the correct answer is the civet bodies, which is not true. So they are asking the false statement or what is not true. Now the next was the buccal mucosal lesion with a pterygium. Now we know that buccal mucosal lesion we see in the bullous group of the disorders also, the buccal mucosal lesion we see in the papillus gummus group of the disorders, but they are saying it is with the pterygium, and pterygium is again a most characteristic sign of lichen planus, and it is always associated with the buccal mucosal changes also. So no second thought, psoriasis no, because it is not having the pterygium, no buccal mucosal changes. Lichen planus, yes. Now why I had given a pemphigus vulgaris and a foliaceus also, because in the pemphigus vulgaris we also had a buccal mucosal lesion, but that is a bullous group of the disorder, but it is not having the pterygium in the nail. So pemphigus vulgaris, it is not the answer, and the pemphigus foliaceus, again here we don't have the buccal mucosal lesions and we don't have the pterygium. So the correct answer is a lichen planus. Now, flaccid bullas with mucosal lesion. And this is again a straightforward question that flaccid bulla, it means it is the intraepidermal bulla. It is not in subepidermal, because if it is a subepidermal, it will be a tense bulla. So it is a flaccid bulla with the mucosal lesion. So in the flaccid bullas, in the mucosal lesion, we had where the desmoglein 3 is affected, and the desmoglein 3 is affected in pemphigus vulgaris. So here the answer is pemphigus vulgaris, not the foliaceus, because it is affecting only the desmoglein 1, and that is not causing the mucosal lesions. Pemphigoid, we don't have the flaccid bullas, all of the above, it is not. So the correct answer is pemphigus vulgaris. Then we had another question with the image given. A child presented with a patch of the hair loss with the exclamation mark. Very straightforward question. The hair loss with the exclamation mark. Exclamation mark, it is seen in alopecia areata. If it is a tinea capitis, that is again a fungal infection we'll discuss today, we'll find this patchy hair loss, but we don't have an exclamation mark, and we have to confirm by 10% KOH amount or by Woodlamp examination. So this is not a tinea capitis. Trichotillomania, again, we don't have this patch like a uniform patch, because we are having the variable hair of a different length, because it's a psychological disorder, and it is not having the exclamation mark. So again, this is out. And telogen effluvium, in the telogen effluvium we are having usually a generalized hair loss, which is because of conversion of the anagen hair into the telogen stage, and the hair loss occurs after the 3 months of basic pathology. So the correct answer is alopecia areata. Now, granular deposits seen on the direct immunofluorescence. Now, granular deposits, because here the antigen antibody complex is in the papillary tip of the dermal papilla, and this is a dermatitis herpetiformis. In the pemphigus, we had a fishnet appearance, so this is out. Pemphigoid, this is the usually dermoepidermal junction is affected. We had a linear arrangement, and the linear IgA disease, again we had the linear deposits in the direct immunofluorescence. So the granular deposits is in the dermatitis herpetiformis. So I think these were the questions what we had discussed yesterday. So now coming back, today we are going to start another group of the disorder, and that disorder is the pigmentary disorders. We all know that pigments are synthesized in the melanocyte, and these melanocytes are present on the basal layer, and these melanocytes synthesize the melanosomes, and in the melanosomes we had a melanin pigment, and these these melanin pigments, they are distributed through the layers of epidermis, and they are causing pigmentation. And we had already discussed that the number of the melanocyte is always constant for the keratinocytes, that is epidermal melanin unit. It means we had one melanocyte for every 36 keratinocytes. Still we had a difference in the skin colors, and this is because of some other reasons. So there could be the certain pathologies where either the pigments are less, or the melanocytes are less, or then we had an hypopigmentary lesions are there, or if there is a melanocytes are more, or the pigments are more, or there's a more activity of these melanocytes which are responding to the sunlight, excessive melanin production, then we are having the hyperpigmentation. So these are the two groups of the disorders, the hyperpigmentary disorders and the hyperpigmentary disorders. So now we'll be discussing the pigmentary disorders in our body. So our topic of discussion is now the pigmentary disorders. Now we all know that different individuals, they had a different shades, and Fitzpatrick, who is considered as a father of the modern academic dermatology, has categorized this into the six groups. So we are having the Fitzpatrick classification. So we are having the Fitzpatrick classification for skin color. Fitzpatrick classification for skin color. Obviously, this is given by the Fitzpatrick. The full name is Thomas B. Fitzpatrick. So Fitzpatrick classification for the skin color is given by Thomas B. Fitzpatrick. And one more question, that who is Fitzpatrick? He is considered as the father of modern academic dermatology. Now he has classified the skin colors into the 6 grades. Grade 1 to grade 6. Now as you could see that some are very fair, this is grade 1, grade 2, grade 3, little bit darker color goes on, grade 4, grade 5 and a grade 6. So if we see the extreme, the grade 1 are those individuals who are having the light color, and the grade 6 are the dark color people. So grade 1 is a light color and the grade 6 is a dark color. Now the quality of the skin is, if it is a very light, it always burn with the sunlight, but it never tans. Because normally what happens, the melanosomes which are present in the melanocytes, they can absorb these rays and they are not causing the damage. But as this is a light color, they had a less pigment, so they are easily getting burnt. So the quality of this grade 1 skin is, it is always getting burn, but it never tan. It always burns but never a tan. While opposite is for the 6 grade skin, which always tan but never burn. Okay. Now the question is asked is, now what is the reason for this different shades of the skin color? As we had already discussed the epidermal melanin unit, that it is always constant. We had a constant number of the melanocytes in the body. So what is the cause of skin color in the different individual? Now the cause of the skin color is due to difference in number of melanosomes and melanin pigment. Difference in the number of the melanosomes. And one more point you can add, difference in the number of the melanosomes, its distribution. Difference in the number of the melanosomes, its distribution, and the melanin pigment. Now, melanin pigment, we are having the two types of the melanin pigments. One is true melanin, another is a false melanin. True melanin is also known as eumelanin, and the false it is called as pheomelanin. So difference in the number of the melanosomes, its distribution, and the melanin pigment proportion of the eumelanin and a pheomelanin proportion. Now pheomelanin, please understand, because it is not asked but it is just for the information, that U is a true melanin which is giving a brownish blackish color. So if you had a more amount of the eumelanin, the darker skin will be there, and if you had a more amount of the pheomelanin, the lighter skin will be there. Okay, so just you can write for your remembrance later on that increase in this eumelanin, it will cause the darker skin, and the increase in the pheomelanin will lead to the light skin. So this is the reason why we had different colors, but you can put a note that is commonly asked is that it is not due to different number of melanocyte. It is not due to the different number of the melanocyte. The melanocyte number is always constant. So the difference in the color is due to the difference in the number of melanosomes, its distribution, and the melanin pigment proportion. You can just add that melanin pigment proportion. That is proportion of the eumelanin and pheomelanin. Clear? Now the question is that how the melanin is synthesized in our body and what are the controlling steps, because genetic deficiency of certain enzymes and their controlling genes will have the deficiency of the pigments in the body. So what is the steps in melanogenesis? Melanogenesis is nothing but it is the synthesis of melanin. So steps of melanogenesis. Now basic raw material is phenylalanine. Now phenylalanine in the liver, it is converted into tyrosine. So phenylalanine in liver, it is converted into tyrosine. Now one very important controlling enzyme is the tyrosinase. Tyrosinase enzyme is a very important controlling enzyme which is converting this tyrosine into the dopa or dihydroxyphenylalanine, and this action happens in the skin, or we can say in the melanocyte. So this tyrosine, it is reaching to the melanocytes in the skin, and with the help of tyrosinase enzyme, it is getting converted into the dopa or the dihydroxyphenylalanine, and further this dopa is converted into the dopaquinone by again same enzyme, tyrosinase enzyme. So in the disease we'll discuss later on, in the albinism, this tyrosinase enzyme is deficient genetically, so there is no conversion of the tyrosine in the further pigment, and throughout the body they had a complete absence of these pigments. So Tyrosine is converted into the dopa by tyrosinase enzyme, which is further converted into the dopaquinone by the tyrosinase enzyme. And this dopaquinone is being converted into the eumelanin and the pheomelanin. Okay, so main controlling enzyme is this tyrosinase enzyme, because if we have to treat the hyperpigmentation, then we are giving the drugs which are inhibiting this tyrosinase enzyme. And if we are having the genetic deficiency, then we don't have any pigmentation. So the most important controlling enzyme in the melanogenesis is tyrosinase enzyme. Okay, now we'll discuss the pigmentary disorders. The first we'll discuss the hypopigmentary disorders. Hypopigmentary means there is a less pigmentation, and then we'll discuss the hyperpigmentary disorders. Clear? So what are the various hypopigmentary disorders? Now, most important is the vitiligo, very commonly asked in examination. The last June exam also, the one question was asked from this vitiligo section. Now, what is an etiology? It is an autoimmune disorder. It is an autoimmune disorder, and where there is a destruction of melanocyte after birth. That is very important, that at the birth the number of the melanocytes are normal, but because of the autoimmune disorders they are being destroyed later on. Now, what are the various types of vitiligo? Now, it can be the focal vitiligo. Focal means any white hypopigmented patch is seen in any part of the body. One or two, three patches are there. Or it can be the segmental vitiligo. Along a particular dermatome, we can have this segmental patch. This was the one question asked in the June exam, and they had given this vitiligo patch on the below the cheek and the neck area, and they asked that what is this patches. So that was a segmental vitiligo patch. So the types could be the focal, or it could be the segmental, or it can be the acrofacial. As the name suggests, acra means hands and facial means face. So when this vitiligo, it is present on the face as well as on the palm and the sole. So this is acrofacial. Clear? Now, one variety or the type of the acrofacial is lip tip deformity or lip tip vitiligo. This is a type of or variant of acrofacial. Now here, the vitiligo patch is present on the lip as well as the tip of the fingers or the tip of the penis. So this is your lip tip vitiligo, where the vitiligo patch is on the lip as well as the tip of the fingers and the tip of the penis. So this is a variant of acrofacial. Or it can be a generalized. So these are the different types of vitiligo: focal, segmental, acrofacial. It can be the lip tip vitiligo or generalized. Now, generalized, when it is covering the maximum part of the body surface area, or advanced stage, it is universalis, when throughout the body, like in albinism, it is universally affecting the skin. It is a white color, not a vitiligo section, means the white color, it is present throughout the body. So it can be universalis. So these are the various types of vitiligo. Now, very commonly in the exam, they give you history, like a patient is presenting with a hypopigmented patch on the skin, and then they will ask the differential diagnosis of what is the diagnosis. They will give you one or two more characteristic features. So what are the characteristic features in the vitiligo patch? Now, vitiligo patch, if you see that it is appearing as chalky white chalky white patch. It is trichrome in color. Trichrome. Trichrome means three colors. And what these three colors means, that in the center, it is absolutely devoid of pigmentation. Then there is a little bit pigmentation, and the outer line is having the normal pigmentation. So inner is depigmented, then it is hypopigmented, and the outer one is normal pigmented. So this a patch which is a chalky white trichome in color, that is three colored pigmentary layers are seen. Now if you see further carefully in a magnified view, that margins are curved, and this pattern it is called as scalloped margin. So this is a white trichrome color patch with the scalloped margins. And in this, because there is a destruction of the melanocytes, but hair pigment is seen. It is not affecting the hair. So in between, there is a pigments around the hair follicles. And that's why it is giving a speckled appearance. चमकता है ना किसी चीज में. So white patch में brownish blackish dots are appearing. So it is also known as having the speckled appearance. So these are the features of this patch. It is trichome color white patch having the scalloped margins and speckled appearance. We are also seeing the true Krobner phenomena. True Krobner phenomenon. And we may also find the medial end of the eyebrows are white. So medial leukotrichia. Medial leukotrichia. So these are the features of the vitiligo patch. It is trichrome, scalloped margins, speckled appearance. True Krobner phenomena is seen. Just message me quickly what are the other two conditions where we can have the true Krobner's phenomenon. Quickly message me. Other than the vitiligo, what are the two other conditions where we can have true Krobner's phenomenon? Great. So it is the psoriasis and the lichen planus where we have the true Krobner's phenomena along with the vitiligo. Excellent, excellent. Great. And in the molluscum contagiosum and the viral warts, we are having the pseudo Krobner's phenomenon. Okay. Now, how we are going to differentiate? This is again a very, very important section, because they will give you, as I said, that they will give you a story that a child is, or the person is presenting with a hyperpigmentary patch, and how you are going to differentiate whether it's in vitiligo or it is the leprosy or the post-Kala-azar dermal leishmaniasis or pityriasis versicolor. So the differential diagnosis is, because in all these conditions we had a white patch. Now, pityriasis alba. Now, supporting points are this is seen in children. Seen in children. Patch is present on the face. Seen in children, the patch is present on the face and this is scaly. So in the children, it is present on the face and it is scaly. Now, vitiligo, it is not scaly. Now, the points in favor of leprosy patch, there could be the loss of sensation, nerve thickening, loss of sensation and nerve thickening. These are the important points along with that patch. If it is in the PKDL is the post-Kala-Jar dermal leishmaniasis. Post-Kala-Jar dermal leishmaniasis. The points in the favor that always there is a history of a fever, patient is from the endemic areas of leishmaniasis. Patient is from the endemic areas of leishmaniasis. Now, question can come in your mind that what are the endemic areas of the leishmaniasis? And they are Bihar, Jharkhand, UP, and West Bengal. Bihar, Jharkhand, UP, and West Bengal. These are the endemic areas. So, history of the fever, patient is from the endemic areas. There could be, if we had a doubt, there will be the positive RK39 dipstick test. So positive RK39 dipstick test will be there, or we can demonstrate the LD bodies in the biopsy. So the point in favor of the post-Kala-Jar dermal leishmaniasis is the history of the fever. The patient is from the endemic areas, positive RK39 dipstick test, and LD bodies in biopsy. Now we can have the white patch in pityriasis versicolor also. The points in favor of pityriasis versicolor: scaly, %% KOH mount is positive, and the typical appearance of the 10% KOH mount in pityriasis versicolor is spaghetti and meatball appearance. 10% KOH mount is positive, giving an appearance of the spaghetti and the meatball, as well as the very important is the wood lamp. Now please message me which color you will find in the wood lamp. We had already discussed at 2-3 points in the pityriasis versicolor. Quickly message me that which color you will get in the wood lamp examination, the pityriasis versicolor. Great, great. I'm very happy that you are able to coordinate or correlate the things. We are getting the yellow fluorescence on a wood lamp examination. Great. So these are the points in feature of the pityriasis versicolor, the scaly lesions, the 10% KOH mount is showing the spaghetti meatball appearance and the yellow color on a wood lamp. Now nevus acromicus. This is again a condition where we can find the white or hypopigmented patch is there. So this is a present since birth. It is present since birth. no increase in the size, as this is the birthmark. It is present since birth. There is no increase in the size, and other factors will be negative. Means we don't have a nerve thickening, we don't have a loss of sensation, our wood lamp examination will be negative. Means exclusion of all other things. So it is present since birth, no increase in the size, and exclusion of other points. Once we exclude that other points are negative, then we can come to the diagnosis that that could be our nevus acromicus. Clear? So this is how we can do the differential diagnosis. So very, very important. Now, please listen carefully. In examination, you are getting the differential diagnosis of 2-3 conditions. One is the hair loss. Another is the hypopigmented patch, and the third will be the hyperpigmented patch. Hyperpigmented patch, we had already discussed the differential diagnosis in the acne, that it could be the melasma, it could be the rosacea, it could be the SLE. Then we had discussed the differential diagnosis in alopecia also, that we have to mainly differentiate from the fungal infection. And here this is the differential diagnosis of the hypopigmented patch. Okay. Now how we are going to treat? Now this depends upon the body surface area involvement. If less than 20% of the body surface area is involved, then we have to give the topical treatment. If less than 20% of the body surface area is involved, we have to give the topical treatment. Either we can give the topical steroids, or we can have topical PUVA or PUVA-sol therapy. This is, we had already discussed, we give the Soraline and then exposed to the ultraviolet A rays or the sunlight, or we are applying the immunomodulators as tacrolimus. But if more than 20% of the body surface area is involved, we have to give the systemic therapy. Either we can give the steroids or photochemotherapy. It is the same name given for the PUVA and PUVA-sol. Photo or photochemotherapy means chemo means we are giving the Soraline and we are exposing. So it is same as, don't confuse it, same as the PUVA or a PUVA-sol therapy. Okay, or we can give azathioprine. Now sometimes when they are not responding to the medical treatment, then we have to do the surgical intervention. Now, what are the conditions where we have to do the surgical intervention? So surgery, the indications are when no response to medical treatment, or it is a segmental vitiligo, because it may be cosmetically affecting in a particular segment we had the vitiligo, or when it is the stable vitiligo for more than 2 years, means the size is not increasing. Otherwise what happens, suppose you are doing a grafting at one patch and this is an autoimmune disorder and after 1 year you had another patch. So when the size is stable, it is not increasing for more than 2 years, you can think of doing a surgery. And what are the type of the surgery you are doing? You can either do a skin grafting, and this we are using a partial thickness graft, or you can go with melanocyte transfer, because the main fault is that there is a destruction of the melanocyte, so we can inject the melanocyte there, and these melanocytes either could be the cultured or could be the non-cultured. So these are the points what we have to remember about the vitiligo, that the clinical features, the differential diagnosis, and the treatment protocol. So this is a one very important hypopigmentary lesion. Now sometimes the destruction of these melanocytes may be because of some chemical induced irritation, and this is called as contact leukoderma. Like you might have seen that some ladies who are putting the bindi, now the glue present on the back of that bindi, it is causing an irritation because they are putting the bindi on the same side for a very long time and they are having this patch. So that's why what we usually advise, that in the night they should remove this bindi. Otherwise they are keeping this bindi for 24 into 7 on the particular fixed site. So they should either remove, or they can just displace. They can just displace from the one side to another side to avoid this contact irritation. Or you might have seen those who are having the allergy to the metal, like a nickel or the plastic sleepers, they are having this white spot on that particular point. So a few points about the contact leukoderma. Contact leukoderma means a white patch at the site of contact. Contact leukoderma. Now here it is not an autoimmune destruction, it is a chemical induced melanocyte destruction. It is different from the vitiligo where we had an autoimmune destruction, and it is a chemical induced melanocyte destruction. And this is at the line of a rubber footwear, we can have the white patch. Or nowadays, some ladies, they are keeping a mobile under their blouse, and because of this metal or the plastic cover, they are getting the irritation and a white patch on the breast area. So this is because of the rubber footwear, and the chemical responsible is the monobenzyl ether of hydroquinone. Monobenzyl ether of hydroquinone. Now one more point you should remember, that most common metal which is causing the irritation is the nickel, because the artificial jewelries, they are containing the nickel and it is causing the irritation. So most common metal which is causing this leukoderma is nickel. And as I said, that it could be because of the bindi, and the chemical is para-tertiary butyl phenol. So in the rubber, it is the monobenzyl ether of the hydroquinone, and in the bindi, it is para-tertiary butyl phenol. And most common metal is nickel. Now another condition where we had an hypopigmentary disorder, it is albinism. This could be again your image based question, and they can give you the image, what is the diagnosis. If you find throughout the body, including the hair, eyebrows, everything is white, it means there is something defect in the melanin production. Or they can say what is the defect, whether the melanocytes are normal, there's a melanin production is poor. So albinism mein, the basic point what we have to remember is the melanocyte is normal. Melanocyte number is normal. There is genetic deficiency of the TYR gene that is responsible for production of the tyrosinase enzyme. So there is a genetic deficiency of the TYR gene that is responsible for the tyrosinase enzyme, and we had already seen that tyrosinase is the main limiting enzyme for the melanin synthesis. So there is no melanin synthesis at all. So this condition is present since birth, and there is extreme photosensitivity. So the main point is that melanocyte number is normal, but there is a deficiency of the TYR gene, or there is a deficiency of the tyrosinase enzyme, so there is no melanin at all, and this is present since birth throughout the body. Clear? Now another condition which could be again your image based question, very commonly asked, is pyabaldism. Now the point in the pyabaldism is that always you find the white patch along with the white hair lock. This is a very important characteristic feature, that a white patch is always with a white forelock of hair. Some bunch of hair are always white along with this patch. And the basic pathology is here is that here is a localized absence of melanocyte. So there is a focal absence of melanocyte in that area, and there is a white patch with a white forelock of hair. So this is pyabaldism. So these are your hypopigmentary lesions. So vitiligo, contact leukoderma, pyabaldism, and albinism. Now I'll see the few hyperpigmentary lesions. Okay. Now one most important hyperpigmentary lesion that is also coming as a differential diagnosis in the various conditions like in acne and all. So hyperpigmentary disorders. One is melasma. Now here you can see that brownish and blackish macules or the patches are seen on the cheek, forehead, malar areas. So the points to remember here is brown black macule or the patch seen on face, over forehead, cheek, nose, and this is because of increased sensitivity of these melanocytes, and they are causing the more production of the melanin. Increase melanocyte sensitivity. So there is increased melanin production. So melanocyte number is normal, but there is increased melanocyte sensitivity or activity leading to the increased melanin production in response to either the sunlight, in response to the intake of the drugs like oral contraceptive pills, in response to the hormones in the pregnancy, and the pregnancy marks which are seen on the face, it is also known as chloasma of pregnancy. So there's an increased melanin production in response to the sunlight, oral contraceptive pills, or in pregnancy. Now we have to do the differential diagnosis from the comedones. Sorry, not comedones, it is an acne. And we had already discussed in the acne, we are finding the comedones, but there is no comedones are present in the melasma. So the point to remember in the acne that comedones are always there. We have to differentiate it from SLE, where we had a butterfly rash. If you remember, we had discussed the butterfly rash, telangiectatic rash, sparing of the nasolabial folds. We all had discussed these points in the acne while we are discussing. We have to differential diagnosis with the rosacea, where we find erythema plus telangiectasia. So we have to do the differential diagnosis of melasma from the acne, SLE, and rosacea. As I said, that this is another very importantly asked the question of a hyperpigmented patch, where we have to do the differential diagnosis. Now, obviously, where there is an excessive melanin production, so we have to give the drugs which is inhibiting this melanin production, and the main important step is the tyrosinase enzyme. So we have to give the tyrosinase inhibitors, as well as we have to protect this area from the sun. So the treatment protocol is that we have to give the photoprotection, protect from the sunlight. That's why sunscreen creams are applied, which is protecting from the ultraviolet rays. Then this is the most important, that we have to give the tyrosinase inhibitors, and which is blocking the melanin pigmentation synthesis. Tyrosinase inhibitors like hydroquinone, azelaic acid, azelaic acid, retinoic acid, and kozic acid. So these are the few commonly used drug which is inhibiting the tyrosinase. And one regime what we are using is the Kligman regime. Now, if you can recall, yesterday we had discussed the two regimes in the psoriasis. One was the Ingram regime, where we are giving the diethanol with the sunlight exposure, and the Gokerman regime, where we are giving the coal tar with light exposure. And this is another regime you can remember is the Kligman regime for the treatment of melasma, where we are giving the hydroquinone with retinoic acid and steroids. Or many times we are doing a chemical peel. Some of us are undergoing the treatment also, who are having the hyperpigmented patch, and they're going to dermatologist, and they had a special aesthetic clinics, and we are doing the chemical peeling also. So chemical peeling is either we are using the glycolic acid in 70% solution, or we are using the trichloroacetic acid as 15 to 30% concentration. So these are the few important points about the melasma. So we should be knowing that how we are able to identify that what are the differential diagnosis and what are the basic step in the treatment, that we have to give the tyrosinase inhibitors. Okay. Now, a few more conditions where we may find the hyperpigmentation. Another is freckles. Now, here you could see, could be again your image-based questions, that excessive brownish, reddish, blackish pigmentation is seen throughout the body, especially on the photo-exposed areas. And this is again here the melanocyte count is normal, but genetically these melanocytes are hyper-reactive to the sunlight. So whenever the person is exposed to the sunlight, there is an excessive melanin production, and this is gradually increasing, and the different shades of the color are seen on the face. So point to remember about the freckles, here the melanocyte is normal, melanocyte number is normal, there is an increase melanocyte response to the sunlight, and this is a genetic. Increased melanocyte response to sunlight variable color macule or patch seen on photo exposed areas. So the melanocyte count is normal. There is increased melanocyte response to the sunlight, and the variable color macules are present on the photo exposed areas. And they gradually increases with sun exposure. Gradually increases with the sun exposure. So the difference in the melasma and the freckle is, in the melasma they are not genetically hypersensitive melanocytes, but because of the exposure they are responding. But in the freckles they are responding in a very severe manner because it is a genetically hypersensitive melanocytes to sunlight. Clear? Now another condition where the melanocyte number is normal, that's why there is a more pigmentation, and that is called as lentigens. So the next condition is lentigens. You may find that hyperpigmented macule or the patch is present, and some children are having it since birth, and we say it is a birthmark because localized there is a number of the melanocytes are more. So lentigens are here, the melanocyte is increased in number. It may be present since birth. It can be present in any part of the body. That is a differentiating point from the freckles because they are present on the melasma, they are present on the photoexposed area. But these lentigens can be present on any part of the body, and they are not increasing in the size. No increase in a size. Whatever the size is present since birth, it is there. So it is the lentigens. Sometimes these pigmented spots are present along with the some other symptoms and what we call as the syndrome. So one very common syndrome we had, that is the Peutz-Jeghers syndrome, where we find that the oral lentigens or in the acral, palm and the sole, the lentigens are there along with the intestinal polyp. So one syndrome is, it's a Peutz-Jeghers syndrome. Peutz-Jeghers syndrome, and in this you can find that there is lentigens or the melanosis on the lip as well as on the hand as well as intestinal polyp. So the Peutz-Jeghers syndrome, we had melanosis on the lip, melanosis on the fingers as well as intestinal polyp. So this is your Peutz-Jeghers syndrome. Now another condition we had discussed while discussing the hair, that excessive hair along with the hyperpigmentation, that was a Becker's nevus. So Becker's nevus, this patch It is the hyperpigmented patch with hypertrichosis. Hyperpigmented patch with hypertrichosis, excessive hair, is the Baker's nevus. Clear? Then one very important disease is neurofibromatosis, where along with the neurofibromas, we are having the cafe au lait macules. And this is again a very, very important image-based question. And they can ask that in which condition this is. It is neurofibromatosis, what these black spots called as cafe au lait macule. So these are the black spots are the cafe au lait macule, and these are neurofibromas. So point to remember about the cafe au lait macule. In short, sometimes we also call them as a CAM. They are seen in neurofibromatosis type 1. Neurofibromatosis type 1. They are seen along with neurofibroma. Seen along with a neurofibroma. These are the neurofibromas are there. Now one important sign is there in the neurofibroma. I'm discussing the important points of the neurofibromatosis here only. The neurofibroma, one important sign is that we are having the buttonhole sign. Buttonhole sign is positive in neurofibroma. Now, what we mean by the buttonhole, we all know that when we are putting the button of our shirt or our dress, that this button is going inside the hole. So same like if you press this neurofibroma spot, sorry, now suppose if you press this neurofibroma spot, you're putting a pressure, you're trying to press this down, so this is totally disappears, it goes inside the skin and like a button is going in the hole. And when you remove the pressure, this is againly coming out because the total hole is there in the skin, and in that it is going down. So we say that buttonhole sign is seen in a neurofibromas. Okay. Now another point of this cafe au lait macule is that number should be 6 or more for diagnosis. The number of these macules or the hyperpigmented patch should be 6 or more, and their size in the prepubertal age, it should be more than 5 millimeter, and in the post-pubertal, it should be more than 15 millimeter. So one question, the cafe au lait macule is seen in which disease? It is seen in neurofibromatosis of 1. What are the important sign of the neurofibromas in the neurofibromatosis? We had a buttonhole sign. Now, how many numbers should be the diagnostic? That should be 6 or more of this cafe au lait macule, and the size should be more than 5 millimeter in the prepubertal and more than 15 millimeter in the post-pubertal age. Now, one more point is that we are having the one more sign in the neurofibromatosis 1, that is known as the crow sign. Crow sign is nothing but it is the axillary freckles in neurofibromatosis 1. Axillary freckling. There is a freckling is seen, or the hyperpigmented patch is seen in the axilla also, and that is called as the crow sign. Okay. Now you can put a note here is that neurofibromatosis 2 is associated with acoustic schwannoma. Neurofibromatosis 2 is associated with acoustic schwannoma. So these are the important points about this picture, that is cafe latte macule. I'll repeat again because this is a very important image and commonly asked in the examination. So they can give you this image and they can ask you that what this is. It is the cafe latte macule, or they can say that in which disease it is seen. It is in the neurofibromatosis 1. It is associated with what other conditions. If they want to make a question little bit more difficult, it is associated with the axillary freckling, that is a crow sign, or what is a buttonhole sign, and what is the condition associated with the neurofibromatosis 2. It is the acoustic schwannoma. Okay, so this is all about this cafe latte macule. Now sometimes we may find the pigmentation in the dermis. Now this all we were talking about the pigmentation or hyperpigmentation in the epidermis. Now sometimes these, as because of the development, the melanocytes are coming from the neural crest, so from the dermis they are going towards an epidermis. So sometimes they can stuck in the dermis and we can have this pigmentation there. But there is a difference in the color of the pigmentation if the melanocytes are stuck in the dermis or they are in the epidermis. If the melanocytes are in the epidermis, okay, you can write somewhere that if the melanocytes are in the epidermis, so the pigmentation if the melanocyte is in the epidermis, it will give you the brown to black color pigmentation. But if the melanocyte is in the dermis, and in the dermis also, in the upper dermis, the pigmentation will be the violaceous color. And if it is in the lower dermis, it will be the slate gray color. If it is in the upper dermis, it is violaceous, or if it is in the lower dermis, it is slate gray color. And the pigmentation of dermis, it is known as ceruloderma. Pigmentation of the dermis, it is known as ceruloderma. So these are the few image-based questions when there is a pigmentation in the dermis in a specific areas along a particular nerve. And these are either the Mongolian spots or the nevus of Ota or Itio. So this is the a few important images of ceruloderma, that is a dermal pigmentation. And one is, you can see this a violaceous pigmentation on the lumbosacral area, and this is Mongolian spot. So Mongolian spot, the point to remember here is pigmentary patch at lumbosacral area. Pigmentary patch at lumbosacral area. Okay. Now this is again a very important image asked in the examination. Identify this image, and here you can see that pigmentation is seen along with the ophthalmic division of the trigeminal nerve, and this is nevus of Ota. You can remember Ota is an ophthalmic division. Okay, so here the pigmentation along the ophthalmic division of trigeminal nerve, along the ophthalmic division of trigeminal nerve, that is nevus of Ota. This pigmentary patch which is present on the shoulder, this is called as nevus of ITO. Nevus of ITO. And here the pigmentation is along posterior supraclavicular nerve. Here the pigmentation is along the posterior supraclavicular nerve. Okay. So these are the few important images: Mongolian spot, nevus of Ota, and the nevus of ITO. Now another important image, sometimes they ask in the examination that identify this image. And here you find this pigmentation along the Blaschkord lines. We had already discussed that these are the lines of the development which are S-shaped on the trunk and longitudinal on the limbs. So these are the Blaschkord lines. So here the pigmentation is seen along these Blaschkord lines. And this condition is called as incontinentia pigmenti. So the point to remember about incontinentia pigmenti, here the pigments are seen along the line of Blaschko. Or we can say the Blaschkoid line also. Here the pigments of the hyperpigmentary macules or patch is seen along the lines of Blaschko, and these are actually the embryologically developmental lines are there. Now another condition where we are also having then excessive pigmentation on the face on exposure to the sunlight, and this is xeroderma pigmentosa. Now, clinically, it is very difficult to differentiate this xeroderma pigmentosa from the freckling. In the freckling also, we are finding the excessive pigmentation on the sun-exposed area, but the cause is different. In the xeroderma pigmentosa, there is again the excessive pigmentation on the sun-exposed areas, but it is not due to the hyperactivity of the melanocytes, but this is because of the defective DNA repair. Defective DNA repair. Now, normally what happens whenever our body is being exposed to the sunlight, some damage happens and body is repairing that defect. But when there is a defect in this repair mechanism, this pigmentation goes on. So this is what is xeroderma pigmentosa. So this is the question asked, that what is the basic etiology? There is a defective DNA repair. And this is in the sun exposed area, and here we are having the extreme photosensitivity and it is prone for malignancies. So this is prone for squamous cell carcinomas. And the last slide in this pigmentary disorders, we may find in the obese individuals or in diabetic individuals, in response to the high in circulating insulin, the blackish leathery patch on the neck, and these are acanthosis nigricans. Now don't confuse with the acanthosis word only. We had discussed the acanthosis means it is the thickening of the stratum spinosum, but here this is acanthosis nigricans, and here it is the black leathery black leathery patch seen on neck and axilla. And this is because of high circulating insulin, and this is seen in obesity as well as in the individuals with the diabetes. Now, I tell you the true story of one of a small baby in my family who was very fatty, and he was an age of around 7-8 years, and we always tell him, बेटा आप अच्छे से नहाते नहीं हो, आपकी गर्दन पूरी काली हो रही है. Or we used to tell that kid, beta, you are not taking the bath properly. The whole of this neck is getting black. And we said, okay, chalo, hum aapko jo hai wo nehla dein. But the kids, they don't want. They said, no, I am just cleaning my neck daily, but still it is black. And later on, when he lost his weight, and suddenly all this pigmentation disappeared. So many times we are not able to correlate that what can be the condition, and we say that it might be because of something else. So this is an acanthosis nigricans. This is again a very important image-based questions. Many times has been asked in the examination that identify this. So blackish leathery patch in the neck or the axilla, and sometimes they give you the story also that it is a patient of overweight or patient is of a diabetes. So these are the a few important points about the pigmentary disorders of the skin. Now quickly we'll revise the slides, and so this was the Fitzpatrick classification. The grade 1 is always a tan. Tan मतलब जलता है, ठीक है, काला पड़ जाता है, और it is never tan and always a burn. जैसे कहते हैं those who are swimmers, their skin tan हो जाती है. So same like the grade 1, it is always burn, but it is never tan, while the grade 6, it is always tan but never a burn. Then we are having the different skin colors because of the difference in the proportion of the U and the pheomelanin, as well as the number of the melanosomes, not the melanocytes. And the most important controlling enzyme is the tyrosinase enzyme. And for reducing the hyperpigmentation, we are giving the tyrosinase inhibitors like kozic acid, azelaic acid, or hydroquinone. Then we can have the vitiligo. Here we can have this trichrome color, scalloped margin with the speckled appearance, and it is autoimmune disorder. We have to differentiate from the various conditions, and if it is less than 20% body surface area, we are giving the local. If it is more than 20% systemic, or we can go with the surgical treatment also. Then we are having the contact leukoderma, either because of the rubber, bindi, gum, or the nickel albinism. The tyrosinase enzyme is deficient. In the pybalidism, the local loss of melanocyte with the hair, white forelock of hair. Then we can have the melasma because of the more activity of these melanocytes to the sunlight. We have to differentiate it from the acne, SLE, or the rosacea, and we are giving the tyrosinase inhibitors. The freckles is the genetically hypersensitivity or hyperactivity of these melanocytes to the sunlight. And lentigens is since birth the melanocyte number is increased, but the size remains a constant throughout the life. And it is associated with the other features like a Peutz-Jeghers syndrome where the intestinal polyp is there. Or we can have the Baker's nevus with the hypertrichosis, capillary in the neurofibromatosis with the buttonhole sign, the crow sign, axillary freckles are there. And we can have the cerebrodermas, that is a Mongolian spot, the nevus of the aorta along with the ophthalmic division of the trigeminal nerve, or the incontinentia pigmenti, or we can have a xeroderma pigmentosa, or we can have the acanthosis nigricans. So this is all about the pigmentary disorders. Now we are going to start. Okay, just relax for 2 minutes, and we will be starting the infections of the skin. So just relax for 2 minutes because we are not taking a break here. We'll take after 30 minutes. So just relax for 2-3 minutes. If you had any doubt, you can message. There is a one query that ceruloderma may only these are the ceruloderma, means the dermal pigmentation, like a Mongolian spots, nevus of Ota and nevus of Itio. The rest are not the cerulodermas. Now, the difference between the melasma and the freckles, in the melasma, the melanocytes are normal and they are responding to the sunlight, making a more of the pigmentation, or they are responding to the drugs. But in the freckles, the genetically they are more sensitive to the sunlight, so they are responding in a greater way. जैसे कहते हैं ना, मेलेज्मा में तो थोड़ा सा ब्लैकिश पिगमेंटेशन होगा, लेकिन फ्रेकल्स में बहुत ज़्यादा हो जाएगा एंड उसमें एक्सटेंसिव पिगमेंटेशन ऑफ द फेस एंड वेरिएबल कलर्स मिलेंगे, कहीं पे बिल्कुल ब्राउनिश हो गया, कहीं पे रेडिश हो गया, लाइक दैट. So because that is genetical predisposition, but in the melasma there is no genetic predisposition. This is only the difference. Now I want the freckle part. Okay. This was the freckle part. Okay, so now if I say that we'll be starting the infections of the skin, and we'll be discussing the skin infections under the different headings based on their etiology. And it could be either the fungal infections, it could be the bacterial infections, it could be the protozoal infections, it could be the mycobacterial infections like tuberculosis and leprosy, and it could be the sexually transmitted infections. So these are the different groups of skin infections, and again the infections are very very important and very commonly asked in examinations, especially the fungal infections and the STDs. These are the very commonly asked in the examination. So now we'll be starting first with the sexually transmitted diseases. Now, although you'll be discussing the different sections separately, like vaginitis, you'll be discussing in your obs-gynae classes also, or urethritis, you might be discussing in your surgical classes. But here, overall, what are the common sexually transmitted infections? And the most important portion that is asked is that they'll say that a person who is a truck driver went to a red light area and after the 5 days had a painful ulcers on the private part, or after the 2 weeks of an exposure had a painless ulcer. So here the two important points are there, that we should be knowing that what are the different characteristics of the ulcers and if they are associated with the lymph nodes, and we have to differentiate whether it is a syphilitic condition, chancroid, as a lymphogranuloma avenarium, or it is adenovenosis, because these are the four important differential diagnoses. Then we'll be discussing that few genital warts are there, how we are going to manage them, or what are the important features of vaginal infections or vaginitis or a urethritis. So first is we are having the herpes infection in the genitalia. So genital herpes. So the points to remember about the genital herpes, this could be your image based question also, that here we are having the grouped vesicles. and which are very painful. So the agent of genital herpes is, it is the herpes simplex virus 2. Now I can put a note here is that herpes simplex virus 1, it is causing the labial herpes.